such an amazing and engaging morning. It seems like we were able to bring everyone back for the afternoon. We hope you enjoyed your lunch, perhaps reflected on and had the opportunity to discuss any of your new learning from this morning's sessions, as we fully anticipate that you'll take some of this back to your colleagues in your communities, in your schools, in your clinics, as it's very important information. We're really glad that you are here to learn it with us. In Warren's opening remarks this morning, he spoke of the impact that Dr. Tater has had on the study of brain injury and his significant influence on our Concussion Summit from its inception. He truly helped bring Warren and Blaine's vision to life. Dr. Tater, though he couldn't be with us this year, was very gracious with his time and recorded a greeting for everyone in attendance. Please take a look.
About the importance of concussion education and prevention, and I know that District School Board of Niagara and its Director of Education, Warren Hoshizaki, who's a good friend of mine, feel passionately about this, and so do I. We have to bring the message to young people about how to recognize a concussion and how to tell when they might have had a concussion. And by tell, I mean they have to tell the coach, the trainer, the teacher, even the director of education wants to know about it so that we can help. We need to be able to identify who may have had a concussion. And I think when you see the Rowan Stringer posters in your school, you see the importance of telling a teacher or telling your parents when you may have had a concussion. It is a matter of life and death, and we don't want to see more young people have terrible consequences of concussion. We want to see young people play sports and be engaged in exercise to keep healthy, but it's got to be done safely.
Dr. Tater's influence is, I'm sure, all around your clinics and your schools, and certainly here today. And it was, though he couldn't be here with us in person, it was really great to have his message and his words. Our keynote speaker this afternoon is Dr. John Leddy. Dr. John Leddy is a professor of clinical orthopedics and rehabilitation services at the University of Buffalo, Jacobs School of Medicine and Biomedical Sciences, a fellow of the American College of Sports Medicine, the AMSSM, and of the American College of Physicians, and Director of Outcomes Research for the Department of Orthopedics. He's a Division I team physician and Medical Director of the University of Buffalo Concussion Management Clinic. He's a member of the expert panel for the Berlin 5th International Consensus Conference on Concussion in Sport. In conjunction with Dr. Barry Willer, he developed the BuffaloConcussion Treadmill test. Dr. Leddy's talk will describe aspects of the physiology of concussion with respect to the autonomic nervous system, cerebral blood flow regulation, the role of exercise tolerance testing in the treatment of concussion. Dr. Leddy comes very highly recommended to the ICS, and we are very pleased that he has joined us from across the river to join his work, to share his work and his expertise. Welcome, Dr. Leddy.
Thanks for that kind intro, Mike. I was hoping you'd get a haircut during lunch, but I guess I should lower my expectations. It's a pleasure to join you here today, and thank you for the invitation. I want to thank Warren, and Blaine, and Mike with the hair for inviting me. I made the grueling drive, 35-minute drive from Buffalo last night, and I was so exhausted. I couldn't even watch the end of the Celtics game. So. But really, being in Buffalo, I almost feel like I'm Canadian, for Christ's sake. I mean, I go to the Sabres games, Sabres-Leafs games, and there were more Canucks than there are Americans in the stadium. And I feel like I got to bring my passport just to get in. So anyway, it's really a pleasure being here, and I hope you get a little bit of flavor for what we're doing in Buffalo. And it's an honor to be here with Dr. Cantu, who's been a mentor and just an icon for me for a long time. I remember going to the ACSM meetings in the 90s and hearing him talk about concussion for the first time. And then, I have to follow Grant Fuhrer and Dr. Cantu and Dr. Stam. And then you put me on after lunch. So Blaine and Warren, that present that's not under your Christmas tree this year, that's from me. I have some disclosures. Thank God I have some disclosures, but they don't have any bearing on the content of this talk today. So Mike went over the learning objectives, so I won't do that in the interest of time. Now remember, you too can have a concussion, so it's not just your patients. I mean, that's pretty lame. Let's move on. I do want to talk a little bit about the physiology of concussion, as we like to call it. That's kind of a broad term, but my training is in internal medicine and sports medicine. I am not a neurologist or a neurosurgeon, so I think of physiology sort of as having to do with blood flow and ATP generation and movement and things like that. And we'll talk about part of the nervous system called the autonomic nervous system. And I know some folks in here may not be too familiar with that, but I hope that you'll get a flavor for what it is after we finish the talk here. So ANS is the autonomic nervous system, and I'm going to talk some about the influence of concussion on the structure of the system, on cerebral blood flow regulation, how much blood is going to your brain, and autonomic function. So this little sort of cartoon here, is this a pointer? Yeah, can I do this? So the brainstem is the deepest part of your brain. It's where your control of blood pressure, respiration, heart rate, keeping you alive, essentially. And right now, hopefully keeping you awake for the next 40 minutes. And basically, it's a system that is unconsciously allowing your body to respond to whatever environmental conditions are imposed upon it, okay? And again, you don't know it's functioning like this. You just react, but you react unconsciously. And it receives information from... Well, I guess I have to react and go to this one. It receives information from the peripheral muscles and blood vessels, from the gut, from the heart, and then it integrates this information and sends it out to these organs to, again, allow you to adjust to whatever the environmental conditions are at the time. And we'll discuss more about that in a minute, but a number of years ago, we got interested in this because, as you'll see, I became interested in using exercise to treat concussion patients. And we wanted to know where in the brain that might be emanating from. And because I just told you that the brainstem controls how you pump your blood and maintain your blood pressure, it's probably pretty important to exercise when all those have to increase, right? So we did what's called a DTI study of the brain, and I think Dr. Stam mentioned this before. It's a measure of the white matter sort of integrity in the brain. But most concussion studies used to look at the cortex, okay, the part of the brain that makes us human. But the most primitive part of the brain, again, is this very deep part. And you see here that in this study of patients who had symptoms for more than a few weeks, there were changes on this particular MRI examination in the area of the brainstem, okay? Now, we don't know really what that means. They were symptomatic. They'd had concussions. Does that mean they have ongoing injury? Does this mean they're healing? Is this an adaptation? We don't know that. We just know that that part of the nervous system can be affected by concussion. And it kind of makes sense because if you look at it, it's at the top of the spinal cord in your neck. And most concussions will involve some sort of degree of rotation, certainly flexion extension, and the neck is often involved, and the brainstem's right at the top of that. So it makes kind of sense from a mechanistic standpoint why that would be involved. Now, that looked like a pretty small area of the brain, right? It was just kind of a small circle. But it turns out that small circle, that small area of the brain, has extensive connections throughout the rest of your brain and hemispheres. And we call this now the central autonomic network. And this, you see this little tractogram here from our group in Buffalo that maps out the connections between the brainstem and these other areas of the brain. And so when you're looking at this, even though it's a small area, it can have widespread effects on your brain. Okay, so even if a small area of the brain is infected, it has connections sort of everywhere, and you see that all these structures are involved and can be affected by concussion, we believe. Now, I think Dr. Cantu mentioned cerebral blood flow regulation, and this is definitely affected after concussion. And a number of years ago, we did a study where we took people with concussion and we took healthy, unconcussed people. It wasn't a big study, but it was informative. And we gave them a cognitive task, this simple kind of math task to solve, and we put them into an MRI unit. We did something called a functional MRI. So you saw before a structural MRI takes a picture of your brain. A functional MRI shows you how much blood flow is going to the brain regions that are being activated in response to this cognitive task. So I'll show you the blood flow in a minute. Now, what we did was we had a group that got exercise to try to help them recover. And then we had another group that did a placebo condition of stretching. So by placebo, I meant we had them doing something to account for the attention you have in a trial, but stretching is different than aerobic exercise in that it won't raise your heart rate. It won't give you a cardiovascular training effect, which we think is important for affecting autonomic function after concussion. And only in the exercise group, is that coming out up there? Only in the exercise group did their symptoms go down. So they clinically got better only if they got exercise. What happened to their brain blood flow, if we look at that? Now, the first one here is the group that got the stretching intervention. So remember, these were patients who were symptomatic for weeks, and then over the next 2 or 3 months, we had them do this kind of stretching routine. And then we measured their brain blood flow after and compared it with before the intervention. And what you see is that they have a lot of brain blood flow to solve this problem. In the MRI unit, they did it over a 10-minute time frame to sort of make it more challenging and fatigue them a little bit. But look at the people who got the aerobic exercise. Their brain blood flow at the end was very different. It was much less to solve the same problem. Now, the interesting part was that the performance between the two groups was equivalent at this point. But only in this group did their symptoms go away. Oh, it's still not there. And only in this group did their brain blood flow normalize to the healthy controls. Now, people who deal with students in school in this audience, you probably know that if you have a concussed student in your classroom, lots of them can start out okay in the morning, but by lunchtime, by third or fourth period, they are shot. They are really tired, and they can't concentrate anymore. They're putting their heads down, and we think one of the reasons is that they're using so much of their brain metabolism to sort of keep up that what they used to be able to do very efficiently, they no longer can, and so they get very fatigued. So cognitive intolerance is something that happens all the time to students, and you can imagine that if they're using all this brain blood flow and energy to try to keep up, that's why they're getting tired. Now let's look at actually the function of the autonomic nervous system and some blood flow information. And bear with me a second, but this is a device that we developed for an NIH trial we just completed, where we put the person in the MRI unit flat down, and then at a certain point we raise their torso up, we raise their body up to drive blood flow to the head. Why on earth would we do that? Because that mimics the blood flow going to your brain that you experience during moderate levels of exercise. We couldn't exercise them in the MRI unit, but we could tilt them to try to mimic that response. So we elevate the torso 6 degrees. Then we measured cerebral blood flow by a technique called arterial spin labeling. Okay, that's just an MRI technique that measures blood flow to the brain, and you don't have to give a contrast agent injection to it, to the patient. Now, we did this for like 5 minutes supine, and then we tilted them up for 5 minutes, and then we rested them down. We measured them 10 minutes later. So they're flat, they're tilted, and then they're flat again, and we're getting the blood flow at every stage. Again, why are we doing this? It mimics the cerebral blood flow during exercise. Now, these are a little busy, and I don't want you to pay attention to the specifics of this. Just knowing that what we did was we looked at patients who were acutely concussed within that first week, and then after they'd recovered about a month later. And we looked at males and females. And then we looked at the cerebral blood flow in that autonomic network I showed you before, that colorful picture of all the connections between the autonomic nervous system centers on the brain. And in acutely concussed males, the ones in the red are the prolonged recoverers, okay? So look at the red line compared to the middle line, which is controls, and the green line, which is the fast normal recoverers. And you see there's a different pattern of blood flow in this part of your brain, which is regulating exercise. The same thing we found in females. This is after they'd recovered. Their, again, the delayed recovery group is in the red pattern here. And don't focus on so much the numbers, just look at the pattern is quite different. And what this means to us maybe is that if there are changes from concussion in the autonomic nervous system of the brain, perhaps if you measure this earlier on, you get an idea of who's going to have a delayed or worsened recovery than someone who's got a sort of a typical recovery. And like Dr. Cantu said, we judge concussions now based upon how long it takes them to recover. So again, these are not published data yet. We're still working on it, but there are differences in brain blood flow, it appears like, in the centers that are responsible for exercise in those who are going to recover normally versus those who are not. Now, another part of the autonomic nervous system is the regulation of your heart rate. So if you ever have an EKG, you probably think, my heart rate is really, really quite regular. But if you look at it very closely, it's actually not. It actually varies a little bit beat to beat, and this is called heart rate variability. And you can measure this, and it reflects the balance of the autonomic nervous system between the fight and flight response and the rest and digest. Now, if you're an athlete, you have good parasympathetic autonomic function, okay? That your rest and digest branch is actually better than your fight and flight branch. That's actually a good adaptation of training, and one of the reasons athletes are who they are. They're very adapted, trained, and tuned autonomic nervous system. Conversely, so their heart rates are actually irregular. That's good. If your heart rate is very, very regular, that would sound like it's good, but it's actually not. That means the sympathetic branch of your nervous system, the fight and flight, is dominant, and that's actually bad for your health and is associated with mortality in people who have diabetes and heart disease, for example. And it's associated with being sedentary. So, looking now at the function of the autonomic nervous system before we looked at blood flow. Now we're going to look at how this autonomic nervous system actually responds in concussed patients, okay? PNS stands for parasympathetic nervous system function. And these are college athletes who've been concussed and evaluated within 1 week of their injury, so they're still symptomatic. They are not recovered, okay? They're actively symptomatic. And the way we assess this is kind of torturous, but we put ice cold water on the face of the patient, okay? And these are comparing concussed with age-matched healthy non-concussed controls. So concussed, non-concussed. Athletes are concussed within a week of injury, and in February in Buffalo, we're sticking ice-cold water on their heads. And what this does is, in a neurologic term, it stimulates what's called a trigeminal nerve in your face and head, and it actually mimics the diving reflex, which is an ancient mammalian reflex, to slow down your heart rate and protect your brain if you decide to dive into ice-cold water. So, even though this is kind of a noxious stimulus, the parasympathetic branch of your nervous system should engage. And if you look at these, concussed thumb here, you look at these graphs here, the concussed patients are in the circles, the open circles on the bottom. The healthy patients have a very nice, you see, increase in this parasympathetic measure, okay, of the autonomic nervous system. But the athletes have a very flat, non-significant response. So it's almost as if they're not able to respond to the environmental stimulus imposed upon them. So their autonomic nervous system is not working correctly. Now, this is not something that they can consciously control. This is like a reflex. This is subconscious control. They can't will this away. So it's not like a response like my head hurts more or, I'm feeling cold. This is completely unconscious, devoid of subjective response. And we've shown the same thing with the other branches of the ANS, which I'm not going to report now. Now, that, remember I showed you, is in someone who was concussed very early on, within days of their injury. This is some data from the Michigan group, where they looked at this in adolescent hockey players, and they measured autonomic function over the long term, okay? So they're looking at autonomic function, much like I did with the heart there, from a bout of exercise in adolescent male hockey athletes. So this is a Canadian relevant study. And they looked at those who had a history of concussion versus those who didn't. So again, these are not symptomatic kids. They are playing hockey. They're okay, but some had a history of concussion, some did not. And then they do this autonomic testing. And I'm not going to show all the, but the bottom graph there shows that those who had a history of concussion did not have as responsive an autonomic nervous system as those who did not, okay? And those who had multiple concussions took more time to achieve this sort of physiological recovery versus those who had only one or no prior concussions. So what this suggests, and we've shown this too in Buffalo, is that even though an athlete recovers and seems to be back to normal, he or she's playing hockey, for example, if you do measures of this autonomic function, some of them are still not normal. So there's this theory now in concussion that clinical recovery, symptoms and signs go away, is not very often coinciding with physiological recovery. That is, the control of the autonomic nervous system, cerebral blood flow, DTI changes in the brain. We can measure changes months and sometimes years out from these injuries when people seem to be okay, yet they're not normal. So what does that mean? Is that conferring increased susceptibility to repeat injury in these folks? Is it conferring risk for long-term damage? We just don't know. But it's what we're seeing on a pretty consistent basis. Now, I told you before, there's these two branches, and I've outlined them here. We have the parasympathetic on your left and the sympathetic on your right. And again, the sympathetic one is the fright and flight. So if the fire alarm goes off right now, you have to engage your sympathetic nervous system to get the hell out of here, okay? You have to run out and, if you're not engaging that, you're gonna get burned up by the fire. But right now, I think you're probably in the rest and digest mode because you just ate lunch, right? Hopefully you're not going to go to the sleep mode during my talk, but right now you should be engaging your parasympathetic nervous system, okay? And what we're just seeing with concussion is that there's a switching problem here, okay? And I'm having a thumb problem. There's a switching problem. So when the athlete has to engage one system at an appropriate time, he or she can't do it, and vice versa. And again, this is a physiological effect of the concussive brain injury. Now, let's move on to exercise. Why would you even consider that exercise might help a concussed patient recover? When we know for certain that if you take a concussed athlete or concussed person and you exercise that person within a few days of injury, you will reliably make their symptoms go up. You can make them worse. You want to make a concussed patient worse? Give them a bunch of exercise to do in that first week. They will guarantee they'll get a lot of symptoms and they'll feel worse. So, but that's the key, is not doing it willy-nilly, is it giving them parameters to work with. So on the left here, I've listed what happens to a concussed brain, and also if you decondition an athlete. And by that I mean you're taking the athlete out of his or her sport for weeks at a time, and now they're starting to lose their aerobic training and conditioning. Now, if you then exercise these people, so we've shown that concussion has deleterious effects on the autonomic nervous system, but exercise improves all that, okay? Exercise actually makes you a better tuned autonomic nervous system. It also improves something called carbon dioxide sensitivity, which I won't talk about today. It improves the regulation of the cerebral blood flow, especially during activity. So if you put an athlete and put him or her at rest for weeks, they lose this ability to finally control the blood flow going to their brain. It's not as good. Neuroplasticity means the ability of the brain to repair itself after injury, whether that's concussion or stroke. And exercise actually upregulates the genes that help repair the brain. One of them is called BDNF. And one of the reasons exercise has been shown to, for example, reduce the incidence of dementia and Alzheimer's disease is believed to be because of this influence on upregulating genes that repair the brain. And everybody who exercises has better mood and better sleep. So there's lots of theoretical reasons why exercise might help a concussed patient, but there are also reasons why you'd have to be careful in them. So, a number of years ago, Dr. Willer and I, Dr. Willer is from Canada, by the way. He lives in Fort Erie, but he's been a professor at UB for 45 years. He goes over the bridge. And someone said he's got Nexus, right? I'm like, yeah, I think he does. Because he'd be late for every meeting if he didn't. We talked about how could we help some of these guys and gals who weren't getting better. I think Dr. Cantu said 20 to 30% of people who have a concussion don't get better in 2 or 3 weeks, and that's correct. So when I was standing on the sidelines for UB football, seeing these guys and gals coming off, most of them got better in a week or two, and this is back in the 90s, 2000, but some of them didn't. And back then, everybody said you have to rest until all of your symptoms go away. That means you can't do any exercise and all of your symptoms have to go away. Well, what if somebody had a headache before the concussion, or they were fatigued one day? Well, that's a symptom, you can't go back to play. So we had some of these athletes who were literally resting in dark rooms and things like that for weeks on end, sometimes months. And lo and behold, they weren't getting any better. And so we tried to figure out how could we help them, maybe this group at least, the group that wasn't getting better, help them get back into sports. And so we kind of took a sports medicine approach to brain injury here and decided to borrow a concept from the cardiac world, where people get stress tests all the time to evaluate the function of their heart. If you ever had a cardiac treadmill test in this room, you know what I'm talking about. Then you have cardiac rehab if you had a heart attack, things like that. So let's apply this principle to the brain, and we modified a protocol from the cardiac world called the bulky protocol, which is a very safe protocol. That's why we used it. Remember back then, people said don't exercise patients with concussion. You're going to make them worse. So our first motivation was safety. It had to be safe. So we borrowed this safe cardiac protocol, and we put the concussed patient on the treadmill, and it goes up very gradually, and we measure their heart rate and how symptomatic they were getting at each stage is a minute, and how hard they were working in terms of how breathless they were, things like that. And through trial and error, we found that if somebody stopped before they should have for their level of fitness, for example, because their headache got worse, or they got dizzy or nauseous, or they had blurred vision, that they were not recovered from their concussion yet. They were either acutely concussed or not recovered, depending on when you did it. And we call that the subsymptom, or the symptom-limited threshold, okay? And we stop the test at that point. We have criteria for that. And we get the heart rate at that point, so we stop the test. Now, initially, we did it in those with PPCS. You remember from Dr. Cantu's talk, prolonged post-concussive symptoms. Why did we do that? Because they were sort of outside of that acute metabolic crisis of concussion that characterizes the first days to early weeks of the recovery. These were patients who were symptomatic for more than a month, so we thought they were out of that more severe danger zone where exercise might really make them worse, and it was safer to do it in this group. So we've published that it was safe and reliable. Now, if you're evaluating someone with this kind of test, and they can go all the way up to exhaustion on the treadmill, and they don't have increase in concussion symptoms, they're just tired or their legs are burned, we declare them physiologically recovered. We think that's cardiovascularly, and probably the control of cerebral blood flow has also gotten back to normal. And we'll talk about that. And then we developed the BuffaloConcussion bike test to collect data, and some people prefer bike, et cetera. Now, first part of what we wanted to do with this was, instead of just treating the patients who weren't getting better, that 25% who were symptomatic for weeks and months, we thought, why not move this earlier on in the recovery process to see if we could speed recovery from concussion and prevent some of those people from going on to the delayed recovery. Because it's really the delayed recoverers that are the problem. They're the ones that have trouble going back to school. They're the ones that are missing seasons of play. They're the ones that are getting depressed and anxious because they're not playing their sport or interacting with their teammates. So this is really the group that we are interested in helping. So this was a randomized controlled trial. So in this trial, we took concussed adolescents within 5 days of their injury, and so they're still symptomatic, right? They're not recovered, and we randomly assigned them to that treadmill test or not on that first day they were seen, and then we followed their symptoms online every day for a month. And what you see here is that the two, whether you got the treadmill or not, the two lines really overlap. Think of this graph as showing, here's time, how many people are still symptomatic. And you can't really see any difference because there was none. That is, if you do the test and you do it the right way, you don't get a bump in the symptoms in the days later, and you don't have any delayed recovery. So if you assess someone's exercise tolerance, as we call it, but you do it in a controlled way and you stop at the test when their symptoms go up, it's not dangerous for them to do that, even within 5 days of their injury, okay? So we then started to think maybe we can treat concussions if we can assess exercise tolerance, each individual's level of exercise tolerance, and give them an individualized sort of heart rate prescription, like a dose of medication. And so the best way to control or regain control of this dysregulated autonomic nervous system is actually by aerobic exercise training. As I told you, athletes who train regularly have very good and very responsive ANSs. And unlike treating something like this with a medication, all of which have side effects, and all of which only treat part of the autonomic nervous system, exercise treats every aspect of it. So it's really the best intervention you can do, if you can make it safe and effective. Okay. So we call it exercise as medicine to treat sport-related concussion. So we put them on a treadmill or a bike. We establish that they can't exercise to the level that they want to. And then we take a percentage of that heart rate they got where their symptoms start. Here, now we use 90% of that. That becomes their target heart rate. And they either go home with a heart rate monitor, or they have one at home or in the training room. And we ask them to do this at the target heart rate for at least 20 minutes a day, or until their symptoms go up, but more than mildly, and then we tell them to stop. If that's at 10 minutes, fine. Do it the next day. If that's at 40 minutes, great. We think more is better. But we tell them to stop when their symptoms go up by more than a little bit. Most people tolerate a bike first because there are a lot of vestibular symptoms after concussion, and running can be a little tough, but most can eventually get to running. We try to get them to do it every day of the week, and we make it progressive. We increase their heart rate in regular intervals to give them a training effect. Once the patient can go to 80% or more of their age-predicted maximum heart rate for 20 minutes or more, several days in a row, without increasing their concussion symptoms, we declare them physiologically recovered. Now, that doesn't mean they go back to sport. That means they can start the return to play program at that point. Okay, so we're not throwing them back into hockey or football at that point, but they can safely start the return to play program. So this is the first randomized trial we published on this in 2019, where we used this idea of doing this very early after concussion. So you can see here they were randomly assigned to either aerobic exercise or this placebo-like stretching program. The age is there is 15, and gratefully in this trial, as it was brought out before, there's a lack of research on females. Almost half of our subjects in each cohort were female athletes, and these are all high school kids. And you can see that they're seen within 5 days of their injury. So this is early on, and they're quite symptomatic still. That's their symptom scores, and that's moderately symptomatic on that particular symptom score. This is like you showed before. So think of this time here, think of these graphs as representing the amount of people who are remaining concussed. And after about a week, you see that the group that got aerobic exercise starts to separate out from the placebo stretching group, and it recovers faster. And at the end, there are fewer people who have persistent symptoms at that 28-day time point. Now, the good news here was that females did as well as males when they were given this prescription. There are more than a handful of studies in the literature showing that females have more symptoms after concussion and take longer to recover than boys. Well, none of those people were ever treated. Now, if you treat them the same way, they recover the same way. Now, what I was hoping that we would find is that if we intervened early, we would have a significant reduction in the amount of people who were going on to that delayed recovery of more than a month. Unfortunately, it didn't happen that much in this study, and we couldn't find statistical significance, even though I think it was clinically important. So we did another study. This was a grant we received from the American Medical Society for Sports Medicine. And we did the very same type of thing. We randomly assigned concussed adolescents to aerobic exercise or stretching. We used more centers. We used a center in Boston at Boston Children's Hospital and one at Philadelphia, the Children's Hospital of Philadelphia. And we did a very similar intervention. And this is the same type of graph. Again, think about this as the number of people who are remaining concussed. And what you see, again, is that after about a week or so, the aerobic exercise group here recovers at a faster rate, and then the stretching group. Now, they all recover, it's just that the aerobic exercise group recovers in about 5 days faster. And at the end here, focus on that, there's a difference in those who have these prolonged symptoms. In this particular group, we had more injured patients because 2 of the clinics were hospital affiliated, so they tended to have more and longer lasting symptoms. And we had 21% in the aerobic exercise group who had prolonged symptoms and 32% in the stretching. And if you gave them the exercise, we did what's called an intent to treat analysis, which means everybody who got randomized to one arm or the other got analyzed in the end. And this is important because it's sort of a real life test of whether this would work. And gratifyingly, we found that if you did the aerobic exercise, you had a 48% reduction in your risk of having this delayed recovery. So this is the first time we've shown that an early intervention actually prevents that half of that group, roughly, from going on to that problematic delayed recovery with persistent symptoms, et cetera. Now, an intent to treat analysis includes everybody who's in the trial, whether they did it or not. And surprise, surprise, some adolescents don't do what you tell them to do, right? But they get included because that's what happens in real life. Not everybody takes their medicine when the doctor tells them to, right? Well, not even I do that. And, kids won't do their exercise. But in an intent to treat analysis, that's what you got to do. Now, when we look at what's called a per protocol analysis, now we're looking at the kids who actually did what we asked them to do, okay? So these are the compliant or adherent kids. And how did we know they were compliant? Well, we didn't just believe what they told us. We sent them home with heart rate monitors, and we recorded their heart rates. And in those that wore the monitors, we were able to compare the aerobic exercise group and the stretching group. And so we know who did their exercise and who didn't. And in those who did the exercise, they recovered about half as fast, twice as fast, roughly, as the ones who really didn't do it or did the stretching. So if you were adherent and you really did what we asked you to do, you recovered much faster than the group that wasn't adherent or that did the stretching. So even an even better effect, and only 9% in that exercise group versus a third had that prolonged recovery. So a better effect. We had no adverse events or near misses, so this is very safe to do in this younger population with symptoms. And so we concluded that early individualized exercise was good for patients with concussion, and even better if they had adhered to it as they should. Now, you've heard a lot about symptoms of concussion. So symptoms are, as everybody knows, there's lots of different symptoms of concussion. Okay, the symptom scales are all 20 or 25 symptoms long, right? But symptoms, and while important, they're very nonspecific. And I think Dr. Cantu talked about this. If you take a depressed patient and have him or her fill out a concussion symptom scale, they're going to look like they have post-concussion syndrome because lots of the symptoms overlap. So in this study, which is under review, we combined the 2 randomized trials I just presented, and we looked at the incidence of delayed recovery, PPCS, okay, not recovering within 29 days of injury. In this, we had better numbers because we combined the trials, 81 randomized to exercise, 97 to stretching. Again, these are high school kids. And then we looked just at their physical examination findings. Dr. Cantu mentioned oculomotor and vestibular findings, and this is what we looked at. We looked at, did they get dizzy when we were moving a finger across their visual field or they were shaking their head? Did they have poor balance on tandem gait test, which is walking one foot in front of the other? So we looked at a combination of oculomotor and vestibular signs, and we divided the groups into those who had 3 or less versus 4 or more. So sort of a less severe group and a more severely affected group based upon their physical examination findings. And I can tell you that kids who have more physical examination findings tend to have more symptoms, and they take longer to recover than the kids who have less. That makes sense, right? So this, a little busy here, but if you concentrate on the top two gray lines, this shows that in the kids who had more physical examination findings, they had a better effect of doing the aerobic exercise than kids who did stretching. So even in the more severely affected kids, now these are not symptoms, these are physical signs the physician is observing, where their ocular motor eye function and their balance is abnormal, they actually did even better with the exercise than the kids who had fewer signs on physical examination. And that was, we didn't expect to find that, okay? We didn't expect to find that. So we're all trying to make the sort of diagnosis of a concussion more objective. And the physical examination is very important. But it shows that even in the more affected kids, the exercise was even, relatively even better for them. This is very busy, and you'll get a quiz afterward if you want to worry. But this is just one way we approach this sort of differential diagnosis of concussion and prolonged symptoms using exercise tolerance testing. And here you have early symptom limited threshold on the treadmill test. That takes us down one sort of treatment pathway. And Dr. Cantu said, you know, concussion is not all the same thing, and it's not. And right now, what is leading the field is that we're trying to identify these sort of concussion clinical profiles, or phenotypes as we call them. Who's got more vestibular involvement, more ocular motor involvement, a migraine phenotype? Who's affected by this autonomic effect more than others? And so we try to classify these patients into treatment profiles to direct specific treatments at them. And again, if there's no early symptom limited threshold, that we start looking for other causes of their symptoms in their eyes, their migraine headaches, their psychology, et cetera. And again, we can use a physical examination and exercise tolerance to help guide us into treatment profiles, and especially help these kids who are having prolonged symptoms. Sounds like I got wolves in this. Well, you're really in the sticks up here, aren't you? God, I can't wait to get back to the United States. No, I'm just kidding. Now, when we do this approach, this is a paper we published in 2016, most of the people who have persistent symptoms, in fact, don't have concussion anymore. They have a combination of neck-related, oculomotor, and vestibular problems. That's the biggest piece of this pie here, okay? So in many people who have symptoms for, say, 4 to 6 weeks, 2 to 3 months, after I evaluate them, I say, you know, you don't have a concussion anymore. You have a neck injury and you have an ocular motor problem, and we have to have you see a physiotherapist. See, I said physio, not physical. Physiotherapist in Canada, and get treatment to your neck, and maybe a visiotherapist for your vision. Is that what you call them up here? Visios? I can't speak Canadian, so I apologize. So we're trying to direct treatment towards specific physical examination abnormalities that are responsible for generating the symptoms in these patients. But by and large, when you test these people, say, with a treadmill, they have good exercise tolerance. Their concussion is over as we think about concussion. Now, this doesn't just work in kids where we do this within the first week of their injury. This is a study from Cincinnati where Dr. Kurowski did the same thing, but he did it in kids who were symptomatic for more than 30 days. So again, this persistent group. So I don't want to leave you with the impression that the only way this works is if you're doing it early on. He took 2 groups. He identified the patients that were persistently symptomatic, and he divided them up into those who got an aerobic exercise group or a stretching group, much like we did. And again, after about a week or so, those who got the aerobic exercise recovered significantly faster than those who got the stretching. So again, a randomized trial, a well-designed trial, not huge numbers, but well-designed, and again, providing information that even if they have persistent symptoms, this is worth trying in younger concussed adolescents. So as I said before, if we can get people back to a baseline level of symptoms and a normal physical examination with aerobic exercise, whether it's in the first week or the first month or the second month, now they appear to be healed, right? They are not put immediately back into Canadian ice hockey, okay? They have to go through the graduated return to play program to make sure that they can handle the vestibular and oculomotor aspects of that sport without getting symptomatic. If they can't make it through that, then we have to treat that specific problem at that point. But we're using exercise to get them to the point where they can do the return to play program, okay? Which is a graduated program that has specific stages. The nice part about this is if you do this and you get better, you can start at stage 3 of that program, not at stage 5, because you've already done the cardiovascular part of it. The first 2 parts are cardiovascular, but you've already done that, and you can start at stage 3. So we can get you back to playing your sport faster that way. Now, I know not everybody has a treadmill and not everyone lives in Buffalo like you want to, but you can do this without equipment if you need to. And we published a paper 2 years ago on various ways to do this if you didn't have a treadmill or you didn't have a heart rate monitor. And what we do is we give the patient a form like this, and so it's very structured and very systematized. And we have them start off at 50% of their maximum heart rate, and then we have them do the exercise on a bike for 20 minutes and rate their symptom exacerbation. So, you know, how bad did you feel, or did you feel anything with that exercise bout? And then we have them progress it based upon how much their symptoms went up in the previous bout. And this actually works quite well too. It's not as fast as the individualized program based upon the treadmill, but it does work. And it's for the people who, you know, and the practitioners who don't have access to equipment. We know not everybody has access to a treadmill. But, so this is one way to do this, sort of the same philosophy or theory, but without needing all the fancy equipment. I promise I'm coming to the end here. So we're building up an evidence base now. The early studies using moderate levels of physical activity or actually exercise on this site here were largely case series or uncontrolled trials, but they suggested that maybe moderate levels of activity weren't harmful to patients with concussion. But now on this side we have a lot more studies now, and toward the end, the newer ones, they're randomized controlled trials, which are the highest level of evidence in medicine that something is working. And by and large, all the trials that I've seen in the past 2 years have shown a benefit of this approach. Different levels of evidence, but I haven't seen one yet that says that this approach is harmful or doesn't work. So we're building up an evidence base about this. So the old view, like I said, was rest until your symptoms go away. And I use the analogy of somebody with an ACL injury here. You know, in the 1980s and early 90s, I wasn't alive then, but I hear, this is how you treated an ACL tear. You put them in a cast, believe this or not, for 12 weeks. And then the physios in here will appreciate this. You took the cast off and you had to rehabilitate the atrophy and the stiffness and everything else for the next 12 months. And that's how torn ACLs were treated, which is why many athletes never got back into play because of it. Well, if you did that now, you'd be sued the week after, because we have very effective ACL reconstructive surgery and early rehab. And now, you know, Tre'Davious White is a cornerback on the Bills. He tore his ACL last year, and you know he's predicted to come back and play, you know, this summer. So, you know, people are now recovering. If the team docs for you, the Bills did that, they no longer be the team docs. And I think for a long time we were putting our brains at complete rest for far too long. I can understand the reasoning behind it in the beginning, because the animal data said that if you exercise the brain, you make it worse. But again, I think many other things in medicine, motion is sort of lotion, motion is good, and if you control it in the right way, then it can be useful and rehabilitative. And I think that's what we're learning now. So the last Concussion and Sport group meeting was in Berlin in 2016. Dr. Cantu and I were there. Maybe some in the audience were there. And the recommendations then started to change. So instead of strict rest until all your symptoms go away, now the mantra is relative rest for a few days, okay? Now relative rest means do whatever you can do as long as your symptoms don't go up. you may have to rest in bed for a while, but as soon as you start to feel stable, get up and move around. Now kids, I use the radical rest here. I don't think a kid should go to school the day after a concussion. I've seen too many times that makes them worse. So, you know, if a kid has a concussion on a Saturday or Sunday, it's my recommendation they probably take Monday off and maybe Tuesday. But after that, once their symptoms are stabilizing, we get them back into school. That's a whole other discussion, but I am not a fan of keeping kids out of school. And we send them back half days with accommodations, but we do not keep them out of school. That is not good for them. But we don't keep them in dark rooms anymore either. And again, once their symptoms stabilize, we talk a lot about cognitive and physical exacerbation thresholds. Identify your threshold, then stay below it. Take a break if you have to, but then get back into it. Identify your threshold and stay below it. Take scheduled breaks. I spend most of my time counseling kids how to do that. And there are active treatments now that are directed at the physiology of concussion. We think exercise is treating this autonomic dysfunction, although we haven't proven that yet. I'd like to, but we haven't done that yet. NIH in the United States doesn't think that that's important, I guess. But there are oculomotor treatments, vestibular, cervical, psychological, cognitive behavioral therapies now that all are emerging as effective treatments for concussion and employed earlier on than we used to. Even in the first couple of weeks, we're starting to use these things to help prevent these kids from going on to delayed recovery. So this is one of my lame jokes. That's my handwriting after residency, and you can't read it, nobody can. But don't cocoon, because now we have evidence-based treatments aimed at the physiology of concussion that can speed recovery, even from sport concussion, which is the mildest of the injuries, and even prevent those delayed recoveries from going on. How soon can you do this? So in the two trials that I showed, the two randomized trials, again, in the first one, they were seen within 5 days of injury, and in the second one, within 6 days of injury, and the range was 1 to 2 days after injury up to 10. So again, we're doing this earlier on, and I know athletic trainers in the United States are employing this earlier on in their athletes, and they're getting good results. So you can do this earlier on. You can't do it in someone who's wildly symptomatic. You have to wait until their symptoms stabilize a bit. But in professional athletes and high-achieving collegiate athletes in the U.S., we're doing this the day after injury in a lot of them. I'll wind up here, and I want to be on time. One of the criticisms of the work was that you're not doing anything to help the brain. You're just reconditioning a deconditioned athlete with exercise, blah, 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 so what? But we just completed an NIH physiology trial where we have found no evidence of deconditioning in those acutely concussed kids versus healthy controls in that first week. And it doesn't make sense they get deconditioned, but on grant reviews, that's one of the criticisms we've gotten. So we're going to publish the data and show, no, in fact, there is no evidence of deconditioning. We're not just reconditioning these athletes. Secondly, the other criticism was that it's only the athletes who feel better who are doing this, and they're going to get better anyway. The ones who don't feel good aren't going to do it, and it's not going to help them because they have too many symptoms or too many signs. Well, what you do in that first week matters. So what we found on our recent trial, but that's okay. Physios in the room know that if you don't push that knee injury a bit and it doesn't hurt a bit, you're never going to get them to recover, right? You just don't want it hurting the next day. But they have to get sore from PT for it to work. Well, the same thing is your brain has to get a little sore to recover, I think. And I think it helps them recover. It prevents some of them from going on to delayed recovery. And the more you do in that first week, the more you do, even though your symptoms may be high, the better you will respond to this. And in Buffalo, again, we don't have data on this, but we start doing this very soon in elite athletes, you know, NHL, NFL, Division I collegiate athletes. We do it soon. Now, well, there's some references. Now, this is the view from South Dakota into Canada. Now, I promise you, us in Buffalo will never do this to you. We're too close to the border. There's Dr. Willer, my Canadian compatriot, mentor, and friend, and I want to thank you for your attention. I don't know if there's time for questions.
Thank you. You just told me to get a haircut. We do have a couple minutes if there's interest in asking questions. I see one going right to the mic right away. A colleague, I believe.
Hi. Oh, this is so high for me. My first question, well, I have a question is, do you think that this protocol, this approach apply to different population than young, active individual, sedentary people, older adults, in people that have other biopsychosocial factors such as anxiety disorders and things like that? Do you think you would have the same ANS response with this population?
Yeah, that's a very good question. So we don't have a whole lot of data, although we're starting to look at it, and there's a group in Toronto who's actually doing this in adults, okay, who have comorbidities. The answer, in my experience, is that yes, it does work, but the response is much slower, okay, because when you have adults with comorbidities, they're going to be their autonomic nervous systems will not be as easily rehabilitated or as tuned. So there's a difference between the trained brain and the sedentary brain, and this has been shown in animal data. So if you take a trained rat and a sedentary rat, you give them a concussion, you give them exercise early on, the trained rat recovers very quickly. The untrained does not, or takes a lot longer, and that's the same in humans. And think about it, someone who has anxiety or diabetes or heart disease, they have abnormal autonomic nervous systems to begin with. And now you superimpose a concussion on that, now you've really messed up the ANS, and it's going to take longer for it to recover. The other thing about adults is they often need other treatments, like Dr. Cantu talked about. They need vestibular therapy, they need neck therapy. I have two populations I see in Buffalo. I see adolescent and college athletes with concussion, and I see adults with work-related head injuries. And they are different. And they need a lot more multidisciplinary approach to get them recovered. But exercise is part of it. So the reason we study adolescents is there are two reasons. They are more likely to get concussions. They're rather homogeneous, though, because they're young, they're rather usually healthy, and they're all getting it by a sport mechanism. Once you get into work-related and car accident-related injuries, now you've introduced a whole other series of complications. But short answer is yes, this does help patients who are adults or other comorbidities recover. It just takes about twice or 3 times as long, and it's only part of their treatment.
Okay, my question is kind of more of a comment. So cognitive processing, like let's say you're a high, achiever, you've got a PhD, you're used to using your brain, and then you get a concussion and you just want to act like you don't, and then you're just keeping going, and so the cognitive processing, like we talk about returning to sport, but let's say you're returning to academic post or something, like you're a very cerebral individual. Like how does that affect your progress? Like for instance, you're concussed, you're trying to perform like you usually do, it's not working. How does that I know it does, it would delay your recovery, but how does it have a long-term impact on that, your brain activity, like in the sense of, is it just for that time?
You can stop doing your job or reading papers for a while to relatively rest your brain, but you can never shut it off, right? What I've observed with high-achieving students and high-achieving adults is that they don't do particularly well with concussion because they're very anxious about their job or their grades in school. And so in those people in particular, if you can get them to exercise, that really helps because it kind of takes their mind off it and gives them something to do that's active and it works. So people who are high achievers, AAA personalities, academics, really struggle with this because they know their thinking is affected and that affects what they do. So they get very anxious in my experience. Whether that has long-term effects, I don't know. Again, the only way you measure severity of concussion now is by how long you're impaired by it. And anxiety over missing school or work or job requirements is a real part of that. So they may need other treatment. I mean, I've had patients who've had to go to cognitive behavioral therapy learn how to deal with that, in addition to doing exercise and maybe treating their neck or whatever. So it may introduce another level of treatment that's required, which is why you need a multidisciplinary clinic. It's different, and everybody needs different parts of this. And for these high achievers or people whose jobs are very intellectual, they become more symptomatic after concussion. And so you do have to reassure them that they will recover, that you understand why they're worried, but if they follow your advice, they should recover just as well.
45 with Dr. Janie Cornway from the University of Ottawa. She's an athletic therapist with over 15 years of experience who has worked primarily with youth and high school tackle football and is also scientific director, clinician, and co-owner of the Concussion Institute. Following Dr. Cornway, tomorrow will be another Ottawa University GG, Dr. Blaine Hajizaki. Dr. Hajizaki is Director, Neurotrauma Impact Science Laboratory, Faculty of Health Sciences at University of Ottawa. Dr. Hajizaki is an internationally recognized scientist in head and brain injury. Part of his talk will be explaining to us all exactly what a GG is. None of us really know what that is. And to conclude, our 8th Annual International Concussion Summit will be Jennifer Botterill. She is one of Canada's most successful athletes and 3-time Olympic gold medalist for the Canadian women's hockey team. She's a graduate of Harvard University and can be seen regularly on CBC's Hockey Night in Canada. So using my best classroom management, don't do anything until I say go. We are moving into break, and we have 3 breakout sessions when you return. All 3 breakouts will be presented twice. The first session is at 2:30 to 3:10, and the second session runs from 2:30 to 3:10, and then 3:20 to 4 p.m. The topic sessions, and you will have received an email about this just this week from our coordinators. It's time to change our approach to return to school after concussion, which is really appropriate after Dr. Leddy's talk. Stephanie McFarland, and that is happening in this room, the Ballroom. The second topic is concussion prevention, identification, management, presented by OFIA. It's in the Lake Huron room. And the session topic, concussion risks, the risk schools face, is presented by OSBI, and that will be in the Lake Michigan